Thank you. Thanks for inviting me for this talk. So over the next 20 minutes, what I'll be doing is I'll be talking about the how we approach an MS patient in the current year in 2025 or maybe 18 or 25, 26. So let me start with a simple case, like in the MS case. This is a 25-year-old lady who has no past history. She has presented with episode of ecological diplopia and imbalance. On examination, she has a left internuclear ophthalmoplegia. She has a bilateral ataxia. And on MRI, there is a left contact enhancing lesion, which is an enhancing plaque, and there are 3 periventricular non-enhancing lesion. And her CSF showed olive choroiditis positive. So she would fulfill all the criteria of dissemination, space, and time of the recent macroarthritis. So of course, she would require a disease-modifying therapy so as to prevent further progression of the disease. So which disease-modifying drug, when to start, and why to start? So we have lots of drugs which are available at present in India. As of now, today 2025, these are the drugs which are available in India, and we are going to get a lot of new drugs. We have interferons, the injectable interferons, which are there. We have lateral acetate, we have targeted interferon. The drugs, the injectables are being used much less and less, many of us. Then we have the orals of teriflunomide, dimethyl fumarate, and lateral is one drug which is being used. There was a drug called microxanthone, which many of us had used 20 years back. The use of it is less now. And then we have the infusions of natalizumab, adalimumab, ocrelizumab, and rituximab. The newer injectable of ofatumumab is there. We have newer drugs which are come up, which are BTK inhibitors, which will hit the market probably next few months. Then we have a drug called siponimod, which is also available globally, not available in India. There is one CD20 molecule which is available globally, which is rituximab, which is not available in India. And then of course we have hematopoietic stem cell transplant. So these are various drug options which are available for treatment of MS as of now, and they may change over the time. Traditionally, how do we approach a case of MS? Start low. Start with a drug which are simple drugs which are called as so-called platform therapies or the first line therapy, and if they fail, you go to the next drug, next level of drugs, which is called a so-called escalation therapy. Start with the first line drug. If patient worsens, go to second line drug. If that fails, you go to third line drug. That's an approach which is used nowadays. So the modest preparative drugs which are used as a first line drug, the platform therapy are the interferons, latinum acetate, dimethyl fumarate, or teriflunomide, and fingolimod. And they are of course increased if patient has worsening of the disease or if there is a disease activity. So when these drugs are started, you always look at whether patient is worsening or not, whether he gets disease activity, and the disease activity is looked by looking at 3 different parameters. Number one, you look at whether patient is getting clinical relapses, what is called an annualized relapse rate. You look whether the disease is progressing in spite of relapses. So patients has a spasticity or motor weakness which is worsening without any relapses, what is called as worsening of the EDSs. And then you look at the MRI activity. Many patients may not have clinical worsening, but they may have radiological worsening, where you can get new enhancing lesions, or there can be worsening or new development of detuated or flare lesions. So these 3 things are looked at, what are called as NEDA. NEDA would stand for no evidence of disease activity. These 3 things are looked in a patient of MS so as to see whether the disease is progressing or not. So we had lots of models so as to decide when the disease activity is worsening. There is one model which was used, what is called a Canadian model or Canadian watch model, which was used to see whether the disease is worsening or not. There was also a model which was called a modified Rio model, so as to decide whether this disease is progressing, whether we are going to step the drug, whether we are going to escalate the drug further or not. However, over the last 20 years, our understanding of the disease has changed significantly. So we have lots of new things which are happening. The rationale of use of these escalation therapy was, of course, these drugs are being used for more than 2 decades. Some of these drugs are being used almost for 3 decades. So we know there are long-term side effects because these drugs have to be used for a lifelong period, maybe in many patients, or maybe very long period. We are always worried about the side effects. So side effect profile, long-term safety data of these drugs has been available. The side effects are well known, probably milder in severity, and the cost of these drugs, of course, is less because patient has to pay from his or her own pocket for use of these kind of drugs. So we know the cost of these drugs as well. But MS is disease which is a dramatic disease. It changes over the time. So just look at this picture. We all know this kind of picture. We keep saying, talking about these kind of pictures in MS. We have a pre-clinical phase, then we have a phase where the disease is relapsing rapidly, and then there is a phase which the disease is having progressive disease. So the relapses would start in a relapsing phase. They will become lesser and lesser as the disease becomes progressive. In the progressive phase, the relapses become less and the disease progresses in spite of the relapses. The MRI activity is there in the preclinical stage, it is also there in the relapsing remitting stage, and when the disease becomes secondary progressive, the MRI lesions do not come. There are no new MRI lesions which are seen in this patient. What worsens is the disease burden which keeps on worsening, and the brain volume which starts worsening right from the preclinical phase. Every one of us will lose our brain volume, but the MS patient lose their brain volume much more compared to normal people of their same age, and the worsening of the brain volume would start right initially and dramatically worsen in the secondary progressive phase. So you can see that MS has these different kind of phases. Initially the disease is having relapsing remitting phase, and then it becomes what is called a secondary progressive phase. So the understanding of this mechanism has made us to change the definition of NADA also. We had NADA 3, then we had NADA 4, then we had NADA 5, NADA 6. The NADA 4 definition says that you just don't look at these three things. That MR activity, the lesion work, the new relapses or the disease progression. You also look at the fourth thing, that there is no worsening of the brain volume. So the NADA 4 looks not only at the inflammatory markers, but it also looks at a measure of neurodegeneration, which is worsening of the brain volume. So this is another thing which is being added as far as NADA 4 is concerned. And if you look at this kind of graph again, little more carefully, you can see that actually there are two different phases in this kind of progression of MS. Initially, there is a phase where the patient has progressive relapses. The relapses become less, and then the disease becomes a degenerative disease or a progressive disease at a later stage. Both these phases of MS are managed by different sets of mechanisms. The first phase, when the patient is getting multiple relapses, that is usually managed or that is usually manifested because of peripherally driven inflammation. There are inflammatory cells, inflammatory lymphocytes in the peripheral circulation, which enter in the central nervous system by breaching of the blood-brain barrier. They would lead to inflammation of the cells, including microglia, including neural cells, including astrocytes. That would lead to demyelinating attacks, and some of these attacks would gradually improve, and the remyelination process can occur in some of these patients. So initially there is a peripherally driven demyelination, peripherally driven inflammation which leads to predominantly demyelination. This is followed by a phase where the disease starts becoming what is called a secondary progressive, and that is usually not because of peripheral inflammation, it is because of central inflammation. There are inflammatory cells in the central nervous system. They are not coming from out, they are already in the central nervous system. They are either meningeal based or some of them can be near the cortices, and those inflammatory cells can lead to expansion of the pre-existing lesions. It leads to atrophy of the brain, it leads to loss of axons further and further, and then there is a significant atrophy which can set in. So there are two different mechanisms by which MS can progress. One mechanism is the inflammatory mechanism, where the MS progresses because of inflammation. And that inflammatory progression can lead to demyelination, and there can be sometimes remyelination. But the second worsening is because of neurodegeneration. And the neurodegeneration occurs because of chronic demyelination as well as progressive gliosis and the axonal degeneration. So there are two different mechanisms by which MS can progress. And these two mechanisms can also be called, can be seen in this kind of graph, where there is first worsening which occurs associated predominantly with the help of relapses, and the relapses associated worsening is called as ROC. It is the worsening occurs when the patient gets a relapse from which he or she has impartial recovery. There is a worsening of the MS disease. That is called as relapse associated worsening. While there are some patients when there is no relapse, still the disease keeps worsening, and this is a phenomenon what is called as PIRA. PIRA would stand for progression independence of relapse activity. So there are two different ways by which MS progresses. One is an inflammatory way, and second way is a degenerative way. So there are two different ways by which MS progresses. So we learned a couple of new terms in last few years. One of the term was ROC, which is relapse associated worsening, where patient gets a relapse. From the relapse there is a partial recovery, and the disease course drops. Patient was walking, starts using cane. Somebody was using cane, starts using walker. There is a worsening in this patient. The disability gradually would accumulate because of the multiple relapses, and that is because of inflammatory disease. And the second phenomenon, as I said, is the phenomenon of PIRA, which is progression independent of relapse activity, where there is an insidious worsening of the patient. There is a progressive worsening of the motor power, progressive worsening of the ataxia, progressive worsening of the bowel motor function. These would occur usually independent of relapses. So even 3 months after the relapse, patient keeps worsening. So that worsening is not because of relapse, it is a worsening which occurs because of independent mechanism, and the mechanism usually is chronic inflammation and a degenerative mechanism. The term which was used few years back, something which was called as wandering MS, was also a thing which was similar to PIRA, which is being described in the current era. So what is the significance of this in the therapy that I was talking for the last few minutes? We know that the way in which patients are treated when you are using the escalation strategies, start high efficacy drug only in the first line drug phase. So use moderate efficacy drugs, monitor this patient, see whether the patient gets a breakthrough disease. If there is a breakthrough disease, then you start using high efficacy drug. So you lose time in this phenomenon. You start using this drug after maybe few months, few years, he gets or relapses, there is progression, and then you use high efficacy drug. You lose time in this. Because once the neurodegeneration sets in, when the patient goes in the secondary progressive phase, we know that the number of drugs are limited and the drugs are also not going to be effective. So one thing that we have learned over the last few years here is that time is important for MS as well. It is not just for brain that time is important, time does matter in MS as well. The earlier you treat these patients, the better they are going to get. So we know that the disease will progress like this if you don't treat this patient. If you do intervention very early in the diagnosis, they are going to progress slowly. If you do intervention late, they are going to progress slow. So time is important for MS also. You have to treat it early, because the earlier you treat it, the better is going to be the prognosis of the patient. So this was one study which was done about 5 years back. This was published in Lancet. Cost of waiting. So what they did for the first time is they used the high efficacy drugs very early in the course of disease, within first 2 years of the onset of the disease. And they compared with somebody where the drug was used 2 to 4 years after the onset of the disease, almost 4 to 6 years after the onset of the disease. And they clearly found that the difference came right at 6 years. And those where the drug was used early in the course of the disease, they progressed rather slow compared to those where the drug was used late. So the conclusion of this study was that you should start using aggressive therapy early in the course of disease. This was a study which was published initially, and then that led to an idea as to why not use the high efficacy drugs early in the course of disease. Something like what cancer specialists would do: use high efficacy drugs, get the disease under remission, and then maybe switch the drugs if needed in some of these patients. Then the strategy of induction therapy was thought in some of these patients, where you use the high efficacy drugs initially and then go gradually reducing the drug if needed if the patient goes in remission. And then that leads to this concept which was published by Giovanni of the flipping of the pyramid. So rather than going from the bottom up, you start from the top and then go to the bottom. The pyramid of first line therapy, second line therapy, third line therapy has been flipped up, and then you start from high efficacy drugs right from day one. So that's the concept of using high efficacy therapies to start with. So concept of induction of therapy in MS is equal to early use of high efficacy therapies in MS. So I talk about this high efficacy therapies for the next 10 minutes. So what is the definition of high efficacy therapy? Well, there's a criteria which is published by Delphi criteria which has been published this year. The definition of high efficacy therapy says that the drug should have effect not only on inflammation but also on progression. So if you compare the drug with any other active comparator, commonest being interferons or teriflunomide which have been used in the trial, the high efficacy drugs should have more than 50% reduction in the relapses, more than 80% reductions in the MR activity. It should also have effect on the disease progression in the form of brain volume loss should not occur with high efficacy drug. The disease should not progress rapidly with high efficacy drug, and of course it should have some effect on the biomarkers also. So patient should have at least, the drug should have at least one effect outcome in the inflammation and at least one outcome from the disease progression. Then the drug is called a high efficacy drug for MS therapy. And the drugs which are used for high efficacy therapies are some which are used intermittently, like cladribine, which is oral drug, alemtuzumab, which is an infusion, and hematopoietic stem cell, of course, which is a single shot therapy, which is serum. And continuous use of high efficacy therapies are either natalizumab or other CD20 drugs. The CD20 drugs include ocrelizumab, ofatumumab, ublituximab, and rituximab. So these two types of drugs, the induction drug and early continuous use of drugs, are called as high efficacy therapy in MS therapy. So again, looking at the graph that I showed you, you can look at in the early stage of MS, when the disease is predominantly relapsing remitting. Patient gets relapses, there is significant MR activity, but also the brain volume starts reducing even at this early stage. So in early stage, the inflammation is very high, but there is also an axonal loss which is starting in this early stage. If you use high efficacy therapy, you can control the inflammation, but we cannot control the neurodegeneration process at this time. So we have a window at this stage, a treatment window, a window of opportunity is available in early MS therapy, where you can reduce the inflammation and reduce the secondary degeneration. You cannot, of course, completely stop the degeneration process, but you can reduce the degeneration process. So there is a window of opportunity which is available early, and that is why the thought process was to use these drugs early in the course so that you can utilize this window to prevent progression of the disease in future. There are a large number of evidences which are available with these drugs. These are multiple large registries which have confirmed that early use of these drugs can have better outcome compared to the escalation therapy where you use low moderate efficacy drug followed by high efficacy drug. The Wells registry says that over the 5 years, EDSS reduction was not significant, was much significant with high efficacy therapy. The US data suggests that there was 34% reduced chances of conversion to SPMS. The Denmark registry suggests that 47% reduction in the EDSS worsening. Swedish registry suggested that there is 30% reduction in the disease progression. And the large Italian registry suggested that even up to 10 years, there was significant reduction of these drugs. So large number of registries have shown in the real world that use of HET early in the course of disease can reduce disease progression. It reduces annualized relapse rates, it reduces EDSS progression, it reduces brain volume loss, it also reduces SPMS conversion. So both ROC, that is relapse-related worsening, as well as PIRA, the worsening which occurs independent of relapses, can be the worsening can be reduced with the help of use of HET therapy. So you have to use these drugs early in the course of disease so as to prevent both ROC as well as PIRA. But the important thing here is you look at the brain volume loss. The brain volume loss is rather unusual for any drug because we know that these drugs act on the clinical mechanism. They act on the inflammation, but they also help for the structural benefit of the patient. If the drugs are used early in the course, you see that if the patient has used moderate efficacy drug initially, followed by escalation therapy, start using high efficacy drug early, the brain volume loss was less in patients where high efficacy drugs was used early in the course of disease. So the brain volume loss or the degeneration process indirectly can also be slowed down with the help of high efficacy therapy early in the course of disease. Of course, these drugs come with concern. There are two concerns with these drugs. First concern is, of course, the long-term safety and safety profile of these drugs. These drugs have serious adverse events like secondary autoimmunity, opportunistic infections, which can occur with these high efficacy therapies. And of course, the cost of these drugs is high, and of course, there are some reimbursement related issues also, even in Indian patients. So these are two important issues as far as the high efficacy therapies are concerned. And the important risk factors are with CD20 therapy, there are infections which can occur because you are depleting B cells in these patients. And of course, there are vaccination related issues. You have to vaccinate some of these patients. With alendronimab, there is a chance of secondary autoimmune disorders, and with alendronimab, we all know of the chance of PML. So you have to proactively look at whether the patient is going to get any of these side effects, and then maybe try and treat them. So alendronimab, almost 1/4 of the patients with alendronimab who develop autoimmune disorders, they commonly include thyroid disorder, ITP, and nephrotic syndrome. So you have to keep doing the blood work in these patients, maybe refer the patient to an endocrinologist, maybe a hematologist, or maybe a nephrologist if needed, and then monitor these patients for any new autoimmune symptoms. So that monitoring has to be done, and with the experience, these side effects can be easily managed. As far as opportunistic infections are concerned, for PML, we know that now we have a good Jesse virus antibody index, and there is this certification which is well known for PML, which has been done for more than 15 years. And as far as other CD20 therapies are concerned, you have to vaccinate the patient with the drugs, with various vaccines, so as to prevent infection. I'll talk about TB also, which is one of the important things which is there with CD20 therapies. And infusion-related reactions, we all have our own protocols as to how do we deal with these patients. Always pre-medicate these patients with steroids, maybe one paracetamol or maybe one anti-histaminic drug, and of course maybe observe these patients for some period. We typically keep these patients for 24 hours when we do the first infusion of any of these drugs, and later of course we do them for the next 4 to 6 hours as a daycare procedure. In malignancy, you have to probably keep doing screening in these patients. So you have to, if you use all these things, you can probably mitigate some of these risks which are available, which are associated with these high efficacy therapies. Vaccination is another important thing for CD20 therapies. Many patients have to be vaccinated before you start CD20 therapies. if you have to give any vaccine, remember that live vaccine has to be given 1 month before starting in therapy, while you can give inactivated vaccine anytime between up to 2 weeks before the first dose of CD20 therapy is given. Vaccinations which are important are hepatitis, so check the hepatitis of the level of the patient. If the patient hepatitis, patient has already taken vaccine, there is no issue. If he is not taken vaccine, you have to vaccinate the patient with hepatitis vaccine. And the second vaccine, which is probably mandatory, is varicella zoster vaccine. So these two vaccines are important when you start CD20 therapy. Other vaccines are probably good idea to give them. They are not mandatory, but it is a good idea to give pneumococcal vaccine, COVID vaccine, and influenza, which is a seasonal vaccine in many of these patients. All these 5 vaccines which have been mentioned here are inactivated vaccines. So we can give them anytime before 2 weeks before giving first shot of any CD20 therapy. And about TB, the expert consensus says that you have to screen the patient before you start CD20 therapy, especially drugs like ocrelizumab. Probably you would screen them either by doing tuberculin test, which probably none of us do. The test that you use is IGRA, which is used as quantiferon gold test in India. So you do this test. If the test is positive, it is said that you have to start treatment with anti-tubercular treatment at least for 1 to 2 months, and then start CD20 therapy, and then monitor these patients over the next 3 to 4 months. Of course, it's going to be a little confusing for Indian patients when TB gold is positive many times. But yes, you can monitor the patient for development of latent TB also, development of clinical TB also when you are starting these drugs. Cost is another issue of these drugs. These drugs are pretty costly. But this is one data, there is no data from India which is available. This is one study which is from Brazil, which said that if you use escalation therapy, you give low frequency, low cost, medium efficacy drugs initially, monitor this patient, he or she gets relapses, treat the relapse, and then maybe escalate the therapy. If you do this, the 5 years cost is roughly 3 to 3 in the Brazilian currency. The cost of using these drugs is actually lesser or maybe equal to the escalation therapy, except ocrelizumab, which is double. The cost of natalizumab, vigorlimab, alemtuzumab, cladribine was much less or maybe equal to the escalation policies which are used, and cost of course rituximab was hopelessly low. So it is not that high efficacy therapies are costly. The cost can be mitigated. If you look at the 5 years use, the non-drug related costs also associated with escalation therapy would be equal. So, the issues with high efficacy, why we don't use them? For 2 reasons. Number one, we are worried about the risks, but a meta-analysis shows that the number of serious adverse effects with these drugs are actually equal to escalation therapy. And with modern pharmacovigilance, the risk mitigation protocol, the safety management is acceptable. And the second myth is, of course, whether these drugs are costly. At least the Brazilian model has suggested that early use has reduced, or at least the cost seems to be same as like what we do have with the escalation therapy over 5 years. We do not have any data from India as of now. So probably the drugs are safe as well as effective, and maybe cost effective needs to be a concern as far as currently in India is concerned. In India, there are issues about infections like TB. We need to have our own protocols as to what we will do about TB in such patients. Hepatitis, cost again is going to be a concern for Indian patients. And of course, insurance coverage of these drugs remains an issue as far as Indian patients are concerned. Many of our patients will be given rituximab as an MS therapy. Many insurance companies are rejecting, saying that MS is not, rituximab has not been approved for MS, etc. And then some drugs which are OPD office drugs, like ofatumumab, there is a concern for insurance coverage as far as India is concerned. So, issue is whether we are going to give these therapies in all patients. If not all, probably you at least try to give to some patients where the disease is going to be aggressive. So we need to understand where, in which patients the disease is aggressive. And again, there is an international consensus which said that if the disease is considered aggressive, if there are certain key clinical features and radiological features. The clinical features are main patient attack. First attack is usually cerebellar or motor or oil bladder. If it is a multifocal attack, if there is multiple attacks occurring every 3 months and incomplete recovery from the relapse, then it is a severe attack, more severe disease. Or if there are patients who have brainstem or cerebral lesions, spinal cord lesions in the first MRI, then it is considered to be a more severe disease. And of course, if there are chronic active disease, then the disease is more severe. So probably at least in these patients, one should try and use high efficacy therapies. So probably the pragmatic middle path in current era with the cost-effective country like India is at least to try and use these drugs in patients where the disease is high-risk patient, and probably in other patients probably you use platform therapies and monitor these patients. So the window of opportunity is there. If you use the drugs early, the window probably can remain open for long period and patient can be benefited. So to conclude, MS is a time-sensitive disease. Time does matter in MS as well. MS progression occurs because of two mechanisms. One is inflammation, one is degeneration. PIRA is responsible for most of the progression of the MS disease. Early damage is irreversible, so that's why you have to use HET early in the course of the disease, which can prevent the progression of disease. Safety issues can be managed with confidence if you are experienced in these drugs. Cost still remains an issue as far as India is concerned. If you are really interested in knowing more about MS and neuroinflammatory disorders, I would like to welcome you for ECPRINTS, which will take place in Pune in next year, June. Thank you very much.